let's say you're doing a study in patients suspected of myasthenia, and you get a complex potential with 5 spikes or 5 action potentials. How many jitter analysis can you make from that recording?
First of all, it depends on which muscle we are talking about. In facial muscle, we may have a few spikes, more than 2. We can have 3 or 4 sometimes. But in general, when we have so many spikes that you're talking about, maybe 5 spikes, then it is a large risk that we're recording from a reinnervated motor unit, due to aging, due to trauma, due to other things. And I try to avoid that and do not include it in the study at all.
Well, in stimulation single fiber EMG, we rely on the idea that every spike represents an individual motor end plate, and we are entitled to measure jitter for each of them. They may belong to different axons, different motor neurons, but it is okay as long as all of them are stimulated well above the threshold. Now, there is actually one exception to this rule. In some neuromuscular disorders, proportion of muscle fibers are split, sometimes really a great proportion. So we have a chance to record from 2 branches of a split muscle fiber, each of which has an action potential indistinguishable from a whole muscle fiber action potential. The only way to be sure about this situation is to make an extra jitter measurement not between the stimulus and the action potential, but between these 2 suspected action potentials. And when we measure this jitter to be less than 4 microseconds, we know that we are dealing with a split muscle fiber. This does not happen in myasthenia, so we have no concern about this in neuromuscular transmission disorders, actually. But it is actually a method with which we can even assess the extent of splitting, muscle fiber splitting in a neuromuscular disorder other than myasthenia, for example, muscular dystrophy or even neurogenic disorders.
In a situation where one finds increased jitter in a muscle and there is an increased fiber density or a large number of motor unit potentials with multiple spikes, then the interpretation of that study should clearly indicate that although there is increased jitter, the presence of multi-spike potentials and increased fiber density indicates that there is a neuropathic process, or likely to be. There is an abnormality other than myasthenia going on, and therefore one cannot conclude that the increased jitter is due to myasthenia. If one excludes all of the multi-spike potentials from jitter analysis and the jitter is still increased, then that makes it more likely, though not as certain as one would like, that the increased jitter in the remaining pairs of potentials is in fact due to myasthenia. On the other hand, if the jitter is normal in all of the simple non-multi-spike potentials, then I think one could reasonably conclude that there is not myasthenia.
I want to add on the situation where we have 4 spikes triggering on one of them and seeing the jitter on the other 3. If we happen to see visually that the 3 are moving together pretty much, then the jitter is mainly on the triggering one, and we will overestimate the degree of abnormality. And since many software have the possibility to re-trigger on spike number 2, 3 or 4, then all of a sudden you can see that the jitter between 2, 3 and 2, 4 is normal, whereas the jitter between 2, 1 is abnormal. Then I should like to add one little comment on increased fiber density being reinnervation. That can actually also happen in myasthenia. Cholinesterase inhibitors themselves are sometimes giving neurogenic changes. So patients that have taken methanol may have a slightly increased fiber density.